story. Okay, we're going to have a lot of fun here now. You ready? Got everything teed up? 6 months ago, I asked about my wife, 66 years old, with, I'm not going to go through this, with T3, stage 3, clear cell kidney cancer. You remember that? We're talking about Keytruda then, and immunotherapy. You reported that Keytruda had just been approved for adjuvant treatment for this. Now, adjuvant means you do not have metastatic disease, but you've got a primary tumor with a high risk of recurrence, and you're taking it to prevent recurrence. So it's like pre-emergent weed killer in the yard. You're not killing weeds, you're hoping the seeds don't germinate. Remember that. It said that she had a spot on her lung, and you, that's me, suggested it be biopsied. We did that, and it was negative. She started Keytruda and is doing well. The oncologist saw her last week and said that he would stop at 2 years of Keytruda if the nodule was stable. But if it was reducing in size or was gone, he might give her longer treatment. What do you think? Now, that's a little tricky question, isn't it? Right? You got that? That's a tricky question. All right, so what that says is that they're treating a woman who doesn't have any evidence of cancer that's spread anywhere to prevent it from spreading, but he's got his attention focused on a lymph node that was there, that was biopsied, that was negative. Now, you remember, I've frequently said that if you take a loaf of raisin bread and make it at home and put 4 or 5 raisins in it, you can imagine slicing it and not cutting through a raisin. But if you've got a couple of cups of raisins in that loaf of bread and you slice it, you're going to cut through a bunch of raisins. Well, same thing. If you've got a lymph node with some cancer in it and you stick a tiny needle in it and come out like that, and the cancer is not totally filling the lymph nodes, you might have a normal biopsy and still be cancer cells in there. Okay, so he's got attention still focused on this node that wasn't totally normal. But the basis of the question is, how long should she take treatment? So it's a difference between, is it spread or is it adjuvant? So put up this next picture here. Now, this is the seminal moment that occurred in cancer that I happened to be, I was practicing and I was aware of this the day that it happened. Who's this?
That's Betty Ford.
Okay, in science, you leave that up there a minute. What's that say?
Betty Ford and the press conference that changed oncology.
All right, when is this?
September 30th, 1974.
That's a long time ago.
Yes.
Take that down now. In science, various experimental sciences, and in medicine, there is what is called that is not a beer truck, that's a redneck. It is. It's a redneck.
Hey, your muffler.
Your muffler.
Please,
Inside.
don't throw me off track like that. I was so focused.
In science, and particularly in medicine, there is what is called the Betty Ford moment that goes to here. Here's the moment. Betty Ford went in the National Institutes of Health hospital for a mastectomy, and in comes hundreds of people from around the world in the press. Surgery starts in the morning, and they had trouble getting her into the operating room, just related to getting the lights on and everything. So, and the operation takes a little while. So they all show up at 8:30. The operation's supposed to start at 9 o'clock. And they're wandering around the lobby of the National Institutes of Health with nothing to do, because she's still in the operating room. And there are over 150 press there. On a little digital board where you stick those little, if you can remember that, you stick the letters up to announce what's going on, it says, Room 107, Adjuvant Breast Cancer Trial Committee. Well, they see breast cancer on that thing there. They don't know what adjuvant means. That word is not part of our lexicon yet. And 150 people show up in a meeting room that's smaller than that place right there, that's got a table, and there are 8 men at that table. And there are about 3 research nurses at that table to discuss the first clinical trial to prevent the recurrence of breast cancer. And they're not presenting it in a fashion to suggest that this is state of the art. It's just to say that this early work we've done seems to be good, so let's broaden the research. They had no intention whatsoever of the world learning of this. This was a scientific meeting. Push this up. This headline hit the world the next day, and this is the article that presented the first clinical trial of a drug that prevented recurrence in people who'd had a mastectomy for cancer. The drug was called phenylalanine mustard.
Say that again.
Phenylalanine mustard, or it's called L-phenylalanine mustard. We abbreviate LPAM. Now, when we talk about clinical trials, we're talking about hundreds and thousands of people, right? This original group had 103 women in it. Only half, 52 women in the world had received this drug. Now, that's not enough to suggest that you change medicine unless it gets in the news with Betty Ford.
It should be enough to say, well, we should do more trials.
That's exactly right.
Yeah.
And one of the things that happens here is in of interest when you go too fast. All right. Mm-hmm. So this hit the world, and that the treatment failure occurred in 30% and less than 3% of those that took the pill. So this looked like it was a big home run. Actually, it was a big home run. Now, let's go to the next one. This is a timeline that sort of has survival at that end and what occurs over history here. So back here on the left-hand side, you just got mastectomy. The doctor comes in and says, Ms. Jones, we got it all. And if there were any lymph nodes positive, and he said, Ms. Jones, we got it all, she had an 80% chance of recurrence and dying. So we got it all doesn't mean much. Doesn't mean a lot, because there's a high chance of recurrence, and that's why trying to prevent recurrence and weed kill was so important. So L-phenylalanine mustard is the first one, but if you look at this list of adjuvant therapies that come along, bring that one down and bring up the next one. This is the history of the evolution of adjuvant systemic therapy. Mastectomy alone, the first adjuvant therapy they mention is not phenylalanine mustard. It's 3 little drugs called cytothane and methotrexate 5-FU you could take by mouth, and that was introduced by a good friend of mine 1 year after this study. Pull that one down.
At that time, what was the #1 cancer killer in women?
It was breast. Still is. Well, no, lung got
lung
got
exceeded
above it for a while, but now lung's coming back down. Okay, now all the things are down. We'll talk a minute about what happened here. So the bandwagon people jump on phenylalanine mustard, taken for 1 year, which is how long that study was done. And we're going to come back to how long do you do stuff here in a minute. But that's the question: how long should this patient be treated? So we're going to get to how you came up with how long these people should be treated. So these people were treated for 1 year in the experimental program. A good friend of mine named Gianni Bonadonna from Milan, Italy, was in this meeting, and he said if you hit this cancer cell from several directions, it'll be more effective than hitting it from one direction only, meaning several drugs instead of one drug. And the 3 oral drugs that you could give for cancer in those days were Cytoxan was a pill, methotrexate was a pill, and 5-fluorouracil, which was an old drug, was given by vein, but you could mix it with orange juice and drink it. So he thought of this to be equal to the pill of L-phenylalanine mustard for reasons that you can't really make sure people are taking your pills when you send them home with them. If you're going to do an experiment, they got to take the drug. He switched over to use IV forms of CMF, and immediately within a year or so had enough data to say CMF is they get better response than you get to phenylalanine mustard, and more people are saved. But phenylalanine mustard was the first one. Now, my extremely good friend, who was the chief of oncology at one of the Emory hospitals, I'll have to keep this broader, people know who he was, wife got breast cancer. After Gianni Bonadonna was making this known, but this had not been published. And Johnny had talked about this at the American Society of Clinical Oncology meeting to a group of us who were having breakfast with him. In those days, the oncologists of the world, when they came to a meeting, met in a Holiday Inn, and there were 150 of them. Now, when the oncologists of the world meet, there are 38,000 of them, and most of them are from foreign countries. So it was a tiny group then. But we knew about this medication. My colleague, whose wife had breast cancer, asked me, said, "Bill, what do you think I should do for my wife?" I said, "Give her CMF." Johnny Bonadonna is going to publish that pretty soon. He says, "Well, it hadn't been published. I wanted to stick with what we know." And he gave her phenylalanine mustard. Well, why did not phenylalanine mustard stick around? A real high proportion of those people got acute leukemia and died of second malignancy, even though they didn't get breast cancer. So you can't jump on the bandwagon when the first article shows up in the National Enquirer in the grocery store until you get enough data to say the side effects or long-term effects outweigh the benefit. And that's what happened with phenylalanine mustard. Okay, put up the next one, because here's the other seminal moment. Who this is?
Oh, wait a minute.
All right. Okay, pull it back down there for a second.
One of the things that you've brought out here is that there are thinkers in the field who are very focused on what is best for the patient and whatever combination or variations need to be done to get to that answer, versus other thinkers who say, "I've got the answer, this is the drug, and this is the way it's going to work."
Well, and the newspaper doesn't do you any favor by saying that this is magic, or we're going to come back to the newspaper in a minute. You see this newspaper sitting here? I don't believe that you can make healthcare decisions, or you can even make statistical decisions about what shows up in the news.
Right.
And okay, so next seminal moment.
Yeah.
Jimmy Carter drug.
What does it say?
Jimmy Carter drug.
It says new immunotherapy drug behind Jimmy
Carter's cancer cure.
Okay, it doesn't say control or whatever. It
Right.
say, wait, one more time.
Cure.
This is a headline in the newspaper.
Right. Cure.
Cure. Pull that down.
And we know you're cured from cancer when you die from something else.
Oh, I'm so happy to hear you say that. You got it. Okay, now.
You've been practicing.
But I every week we're talking about Keytruda, and I always say we tell the patient it's the Jimmy Carter drug, and he's been taking it for years. Now, did he take it for years? That's the next question. Remember, when do you stop the immunotherapy for this patient here? He had the disease in his brain, liver, and lungs, so he wasn't taking it from an adjuvant perspective. So now, quickly, we're going to go through what's Jimmy Carter's drug. So what's the next one?
What is immunotherapy?
Immunotherapy. All right. You got good on that one. All right. So, immunotherapy is not chemotherapy. It's not radiation. It's not surgery. We've done this 100 times in the last 110 programs. So, what does that one say?
Unleashing the power of the immune system to defeat cancer.
All right. So you got that up there for just a second. We'll leave that up there a minute, because we talk here about targeted therapies and things that go to the gene that are not Keytruda and aren't that type of immunotherapy, but stimulate the immune system in one way or another, or block immune responses that are making the disease more aggressive, or in some way manipulate making antibodies with the vaccines we've talked about. So you can pull that down now. There's lots of different ways you manipulate the immune system in cancer. So the next one here, we've always got to worship at some shrine. What shrine we worship at? The National Comprehensive Cancer Network algorithm for treatment of kidney cancer. And if you go through this big old long thing here, immunotherapy with this drug is the top thing on the list. We remember it's just been a few weeks since, it wasn't this case because that was 6 months ago, that we were talking about. We had nothing for kidney cancer or melanoma until Jimmy Carter's drug came around. All right. So this last picture, you don't know Suresh Ramalagan, but Suresh is at Emory. He's a really nice guy, and the thing that makes him so sought after is, not only is he an attractive man, but he's a really good speaker, okay? So what does it say? How long should we give immunotherapy for? Pull that down now. Suresh, in this particular talk that I happened to go to, said, and we've gone over this with Ray a million times, the clinical trial was done giving the drug for a certain period. I said, now, he says in this, the clinical trials for immunotherapy for lung cancer were at 2 years. Therefore, the data is you stop at 2 years. Well, if you still got active disease, don't stop at 2 years. You continue the drug. Now, when we get to the next question, you're going to hear that again. Continue until relapse. Don't stop when the time period's over. That's metastatic disease. So let's go back. The phenylalanine mustard given for a year caused leukemia. They dropped back to try it for 6 months. That gave leukemia. That drug went away. When Johnny Bonadonna started his CMF program, he gave the drug for a year. It was dramatically effective, but it also had side effects. So the question that Johnny and the rest of the people asked, well, is a year necessary? Can you give it for lesser time? So they tried it for 6 months and a year. Clinical groups going side by side. The clinical benefit was as good in the 6 months as it was in the year. The toxicity was less, so nobody gave it for a year. I was part of all these clinical trials. And then, well, the question is, if 6 months is good, and it's as good as a year, is 3 months as good as 6? So we did the clinical trial of 3 months versus 6 months. It wasn't as good, so we bow at the shrine of 6 months of adjuvant therapy for cancer of the breast. Does that help you a little bit?
A little bit.
So these all come out of what happened before. So let's go back now to this lady and the lymph node. What this tells us is, if that lymph node shrinks or goes away, it was not a benign lymph node. There was cancer in it, and therefore you have changed from weed killer to prevent recurrence to I'm actually treating a recurrence that we didn't make a firm diagnosis of with that needle. So you're going to have to listen to your oncologist. 2 years is the standard for the reason that I just gave. We're not positive that that's the right answer, but that at least as of today seems to be an adequate length of time. The clinical benefit seems to be good in adjuvant therapy, and it may be 2 or 3 years from now we tell you can give it for 1 year, or 2 or 3 years from now we tell you do a little bit better if you go longer, because those clinical trials are ongoing, but they have to have many thousands of patients to make that benefit. Go back and remember there are only 43 patients in that phenylalanine mustard thing when we changed the way we acted. So that's the story. Follow his instructions.
Thank you, Northside Hospital Cancer Institute, Georgia Cancer Specialist, for this segment. We appreciate it. All right.
Okay, now I want to say that I always say Ray's the guy that does the research in his practice every day. We do clinical trials for cancer here, but the thing is, people need to remember that when they give you an opportunity to participate in a clinical trial, and Ray talks about the informed consent form as big as a New York phone book, they would not be able to get that clinical trial to humans after they've tried rats and mice unless the best thinking is that this treatment is equal to or better than what the best we've got, or equal to and less toxic than the one we've got, or equal to and less some other reason. I mean, if you got something you have to take 3 times a week by injection that's this good, like penicillin for strep throat, only available in a shot, right? And then you got penicillin pills. Well, it's a little easier if you got penicillin pills. So, I mean, it's going to be you
have to prove superiority and safety.
Yeah. So if you participate in a clinical trial, you're not being experimented on. Is my point. Go ahead, Ray. I want you to run with it.
Well, I mean, that's important to sell folks on the notion that when you have the opportunity to do a trial, look at the consent documents and be inclined to do that. Now, you have to make your own. Talk to the investigator, talk to your doctor, your family, but be so inclined, because you are improving our state of health in the world.
Yeah, but the only thing that you got to look forward to in terms of effectiveness is, to the best of the science ability, this is as good as the best we have available.
Right.
And they wouldn't be doing it if they didn't think
It
it's
wasn't
either
breaking new
better
ground. Right.
or less toxic. Okay, well, I mean, because I think clinical trials are really important, and the fact that this clinical trial with phenylalanine mustard turned out great in terms of it told us that you could prevent recurrence, and turned out poor in terms of there was a long-term side effect. A lot more people were benefited than got acute leukemia. So I don't mean to indict it, but it went away quickly and was